good afternoon, good morning, good evening, depending on where you are. We get started with our webinar today. Thanks for joining. Okay, we'll get started and let others join as they come in. Welcome to our webinar on evaluation and health equity from community science. I'm Anna Ghosh, one of your hosts today. So before I get started with the content, just want to let you know that if you're having technical issues, please type them into the Q&A box you'll see at the bottom of the screen. We will have time to answer questions at the end of our presentation portion. So if questions come to mind as we're going through the content, feel free to add those to the Q&A as well. And Toby Bray on our team will be monitoring the questions, and he'll also be able to help you with any technical issues you might have. And just one common question that comes up often, all of you who are registered for the webinar will receive a copy of the presentation following the webinar. So moving into what we hope you will take away from today's presentation, we are going to present a framework for evaluators whose goal is to promote health equity. We're going to give you tools to identify the drivers and indicators of health equity, and hopefully you'll walk away with a starting place to use evaluation methods to advance health equity. Before I get into the agenda, I just want to note that we're all learning and challenging ourselves in this intersecting space of evaluation and equity. Our approach is to be in a stage of continuous learning, including in co-learning with our audiences. So we'll present our approaches and we'll open it up because we're curious to hear your feedback, your experiences, your questions, so we can continue our learning as well together. So for today's agenda, we're going to briefly go through introductions of ourselves, and then we'll talk about the building blocks of health equity, and then pull it together using a systems lens for evaluation, and of course going to some practical application in planning and designing your evaluation. We'll wrap up with a quick summary and then move into discussion and questions. So here are the faces of community science. We are a team that applies research and evaluation to advance social justice and equity. If we haven't met you yet, we're glad you're here, and we hope you stay in touch. So again, I'm Anna Ghosh, and I'm joined by my colleague, Michelle Revels. We are your hosts today for this webinar. We both come from a background in public health and evaluation with a focus on health equity. As we get started, I want to take a few minutes to level set. We thought it would be a good idea to have a common understanding of the terms we're using today: equity, structural racism, health disparities, and health equity. So it's important to have this clear understanding of the terms, because without a shared understanding, it becomes difficult to really operationalize how these concepts fit together, what the indicators are that we need to be using, and how to measure progress, which we hear a lot of people asking about. So we want to take the time up front to go through these definitions before we describe how they all relate to each other. So we want to start with equity. What is equity? The term equity is getting used a lot, as you probably all know. So here's the definition we're using to describe when equity is achieved. In order for equity to be present, people need to have fair access to the resources and opportunities to reach their full potential. And they not only need access, but also the rights to those resources and opportunities. And furthermore, the conditions need to be present for people to be able to actually take advantage and use these resources and opportunities. And then finally, while doing so, people need to be free of discrimination in order to obtain the resources and opportunities that are granted in the institutions and the law. And I just want to say that when we talk about equity, we also acknowledge the role of power, power in being able to realize each of these. because those who have power have influence over all of these factors that lead to achieving equity. So moving into health disparities. Disparities is the thing you can see. It's about the difference you can measure in health or access to healthcare services when you compare the different racial, ethnic, socioeconomic, gender, differently abled, and other historically marginalized groups. So disparities are something that we often measure by disaggregating the data. And when the data shows that there are differences by these different marginalized groups, it's telling you there's a symptom that something is going on and alerts you to the fact that there may be an area for concern. So moving from equity to health equity is similar to equity, but it's specific to healthcare resources. So where people have the ability to take advantage of these healthcare resources and opportunities so that they can reach their full health potential. And structural racism. So structural racism is one of the most powerful, maybe most pervasive forms of structural discrimination. Remember, I said health equity is about having access, conditions, and rights. Structural racism works through laws, policies, practices that cooperate through multiple systems to deny or limit access, conditions, and rights, all based on race. And structural racism basically takes away the freedom from discrimination, from experiencing discrimination. And again, power shows up in determining the laws, policies, and practices in the systems to determine who benefits and who loses. And it's those who accumulated or aggregated power in their racial group that get to have the voice to decide what the laws, policies, and practices say. And just want to note here, because we'll be talking a lot about a systems lens, that when you're talking about structural racism, because of the systems that are inherent in structural racism, you are applying a systems lens. So I want to pull it all together here, the terms that we've talked about, and why structural racism is so important for addressing health equity. So I just mentioned structural racism uses the tools of laws, public policies, and practices. And the way these are crafted through structural racism results in the fact that some benefit from structural racism, or in other words, it gives advantages to some racial groups and then disadvantages to other racial groups. And those who benefit end up with better places to live. They get better education, better jobs, they have safer and cleaner environments, healthcare. And then those who do not benefit experience more harms in their neighborhoods. They don't have access to quality healthcare, education, jobs. They lack the space to enjoy life. These are all the things that I'm talking about. They make up the social determinants of health, which are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect health functioning, outcomes, and risks. So structural racism is the thing that negatively impacts the social determinants of health. When we start out, social determinants of health are not in themselves positive or negative. It's the structural racism that makes them different. And when there are those differences in the social determinants of health, it means that not everyone has access, capacity, and rights to resources and opportunities. So that's when we see the disparity or the difference show up in health status. And when there's a difference in people being able to achieve their best health, that's what results in health inequity. So after going through this to show you how we get to health inequity, I'm going to pass it over to Michelle Revels to talk about how do we get to health equity.
Thank you, Anna. So you can see this is our conceptual framework that we've developed to really talk about what's the pathway to improving health equity. And as you, from Anna's wonderful explanation of how we get to health inequity, you see that we actually center structural racism as one of the most important drivers right? In this conceptual framework. But the way we center it is saying that in order to get to health equity at this population level, we must intervene on those policies, practices, and other norms that cumulatively deny or limit access to opportunities and racism, as well as strengthen the capacity of communities that are affected by these disparities, so they can frame the issues and drive the solutions. So in this model, we're using our program strategies and initiatives to intervene on structural racism as a primary driver, with the goal of increasing or making progress towards racial equity, which will then positively influence those social determinants of health that Anna just talked about, and then lead us in the end to this reduction in disparities, so narrowing that gap, and then ultimately improvements in health equity at the population level. And I want to reiterate something that Anna said, because what we're looking at here is trying to think about those improvements in health equity. In order to have improvements at that magnitude, we are talking about using a systems level approach that will bring about the change that we need to see in order to move just from improving health outcomes of individuals, but to improving population health as well, which ultimately results in the health equity. So we at Community Science really was thinking long and hard about how do we talk about the ways that as evaluation, we can sort of measure this progress towards health equity, and what does it mean to measure progress towards health equity. And after a lot of internal conversations based on our learning and experience, developed this framework, which we call the evaluation, learning, and continuous improvement process. And what it does is say that in order to measure that progress on health equity, it's important for us to have a very grounded understanding and a realistic expectations regarding to what extent a strategy, an intervention, or a program may be influenced by or actually influence structural racism, right? We need to understand that at this outset so that it can guide the way that we move through the evaluation process. So for the rest of this conversation today, what we're going to be talking about is really focusing on the planning and design phase of the evaluation process, and discussing how structural racism, how we can account for structural racism in that planning and design phase by applying this systems lens and making our assumptions very explicit around what role is racism, structural racism playing in the problem at hand. So to do this, we're going to be employing what we like to call as our systems tree, right? This is our systems lens, where we start to have this conversation around how do we make the role and influence of structural racism more explicit. I think the key takeaway that I want you to have from this is that it's important to be intentional about this conversation and to intentionally name and to have these upfront discussions around structural racism. So when we talk about the systems lens tree, we start first with those symptoms, right? What are the disparities that you can observe? And they're at the tree level, people see this, and it kind of is our first indicator that there's a problem. Then this leads us to having a deeper conversation of what's causing those disparities, what's linking these symptoms over time. What are the patterns and the trends that we need to understand in order to be able to intervene on those symptoms? Which then leads us to these conversations around, well, what are the systems and the organized entities and relationships and policies and practices that really hold and really support these patterns and trends, and they contribute to them, and it's the reason why we see them. Then lastly, we begin to focus in on these mental models and these narratives. And there's a reason why they're down here at the roots, because they're often unseen, but they are the drivers of all these things that we have, that we actually see these symptoms, right? So what are those frames, those that shape the way people think about this problem, and it becomes baked into the systems, right? Baked into the relationships, baked into the policies, baked into the practices. Because structural racism is a systemic factor, we use this lens to help us have and guide these conversations about the way that structural racism is either influencing our problem at hand that we're being evaluating, or the way that the intervention or strategy is trying to actually intervene on structural racism. So we wanted to give you an example of how we apply this and the way that we think about it, so that you can begin to see how to have these conversations around the role and influence of structural racism. So this is what we kind of call a basic theory of change and logic model. One that we're kind of just looking at a problem without necessarily applying a systems level approach. And our problem at hand today is the prevention of preterm birth and low birth weight, because as we know, preterm birth and low birth weight are primary drivers of infant mortality, and particularly disparities in infant mortality. So for this particular intervention strategy that we're talking about, we know that the goal is to reduce the incidence of preterm birth and low birth weight in order to improve infant health equity in the long term. The intermediate outcomes focus on increasing the use of prenatal healthcare services for prevention, diagnosis, and treatment of preterm birth and low birth weight. So ultimately, that's what we want to get people to use in order to achieve our long-term outcomes. So to do that, we have one of the strategies will lead to some improved birthing parents and family health behaviors, right? So parents eating more healthy, understanding the importance of early prenatal care, and then being able to access this. We also wanted to focus on the provider side of things, right? So because it's not just the parents, it's also how providers contribute to this. So to what extent are there improved adherence to recommended standards of care by both providers and birthing parents? So ideally, we start to think about, if these are our goals, what are the activities that we want to engage in to accomplish this? And so for this particular strategy, the focus is really on education and outreach to birthing parents and families around the importance of preventing preterm birth and low birth weight. For those providers, the focus is on training and professional development for physicians, nurses, and other health professionals. And then our inputs to support this particular intervention activities are commonly our grants and community partnerships, where we will be designing these programs and intervention strategies really focused on this education and preterm birth and low birth weight. So as you can see, it's a fairly straightforward approach to being able to tackle this very serious issue of preterm birth and low birth weight. So if we think about this as approach and we start to think about, well, we as evaluators, we know that when you think about preterm birth weight and low birth weight, there's some structural issues that are affecting this as an outcome, right? And then we know that there are disparities. So one of the first things that we would ask using that systems tree is like, what are the disparities? Which racial ethnic groups are most likely to experience preterm and low birth weight, and why? And that why piece is where it's critically important, because that's where we're starting to begin to sort of unpack what is that role of structural racism? What is the history of things such as residential segregation, low economic opportunity, high levels of employment? How do all these factors begin to contribute to the symptoms that we're seeing? Equally as important in this step, and sometimes I think is a piece of this that often gets overlooked, is that we need to ask ourselves at this point, is our data sufficiently disaggregated so that we can know who's disproportionately impacted? Sometimes it's not. Sometimes you only have data, often just black, white, other. If you want to dig a little deeper, can you see how different groups are also disproportionately impacted? And if not, this could be a place where, okay, then you think about, where do we get this data from to know this? How might we learn more about other disproportionately impacted populations if it's not present in the secondary data that's readily available to us? Another symptom that we may see in this particular scenario, because we're talking about providers, is, are there some providers who seem to be doing better than others in the sense of their patients are less likely to experience preterm low birth weight, they're more likely to adhere to the standards of care, or they're more likely to, or someone may not be adhering to the standards of care, and why not? What is driving that? To what extent, as we start to dig deeper, and we'll go into this when we talk about patterns and systems, to what extent are there other contributing factors that may be resulting in these disparities that we're seeing in the care that's provided? Different racial ethnic groups, or groups that may even be different by income status. Again, we want to ask that question, is that data sufficiently disaggregated so we can be able to better understand those systems? Then as we start thinking about this systems lens, we want to be very intentional about asking those questions about what other outcomes are affected by this low or inadequate utilization of prenatal healthcare services, and why. Are there some factors that are related to structural racism that are leading to negative social determinants of health, such as are there fewer healthcare facilities in certain neighborhoods and it's harder for women to be able to access this prenatal care? Are there feelings of not being comfortable accessing prenatal care? Is it lack of insurance? These patterns and trends begin to help us go deeper into what role structural racism may play in this problem. Another pattern and trend is like, well, do people have what they need to take a full advantage of the services to prevent pre and low term birth? And if not, why not? What are the drivers of those differences? And then we get to the systems part. And this is where we can begin to really very explicitly explore and ask the question, which can be a very hard question sometimes, depending on your audience, who you're working with, and how they are perceiving what their program is. But the question is important to ask, like, how has or does racism affect those various social determinants of health? Like Anna was talking about earlier, like education, housing, healthcare accessibility, affordability, as well as the larger community context and neighborhood and built environment in which individuals are living in, and then to what extent do those contribute to these symptoms that we're seeing, which is disparities in preterm and low birth weight, and for whom, right? And sometimes it's not only disparities between groups, sometimes it's disparities within a group. But being able to ask those questions can lead you to a more nuanced understanding of the problem, as well as potential barriers and facilitators that you need to address or to think about or to explore further as an evaluator. Another big important systems question is like, who is and who is not able to access the opportunities that are provided? Who can take advantage of the education and outreach? Who is not able to take advantage? Who can take advantage of the care? Who's not able to take advantage? Are there enough providers? Question. And then lastly, but by no means least importantly, is really starting to unpack those mental models and narratives and really asking the questions, having the conversations about that. Are there implicit or explicit narratives that exist about why preterm birth and low birth weight is occurring? Is there a prevailing narrative around who accesses prenatal care early and who doesn't, and why they do and why they don't? Is there some sense that if you don't access prenatal care, you are, quote, a bad birthing parent? What does that mean? Can we break open those narratives and see how they vary by race and ethnicity? And then what drives those narratives? And really ask, are the narratives different for women of color or birthing parents of color than they are others? Are they different by birthing parents of different economic status versus others? How do they shape not only the care a birthing parent might receive, but also the systems that are providing that care? Then lastly, because this is a strategy that's really focused on education outreach, there's an assumption that there's a lack of understanding of education of the importance of prenatal care, of education around preventing preterm birth is a main reason for these disparities that we see, but maybe not. And if it is, who is making those decisions about education and the outreach that's needed? Who has the power to determine what is taught, what's not taught, who is taught to, who is get delivered, and how it's being delivered, and why those decisions? Similar to who has the power to determine who's a provider and not a provider, particularly in this space. Like, is a doctor always the best provider, or can a doula do this? And then to what extent is our mental models about who is ability to provide care and who isn't, it begins to influence how that care is provided. So what I'm hoping that help you see is that when we are very intentional about the conversation, about exploring structural racism, that is going to lead us to being able, and when we're very intentional about exploring structural racism, and asking these questions and engaging this evaluation team or the programmatic team in these conversations, this begins to shape the way that we approach our evaluation objectives, our evaluation questions, the way we think about the data that's needed, because if we really want to explore these disparities, then we need to have that disaggregated data. That's so important for us to be able to monitor over time to see whether or not progress is being made with the groups that we want to see the progress in. How does it impact the way that we go and collect the data as well? So it has that ability to really shape the way we approach the evaluation planning and design process, which then ultimately shapes how we collect the data, what data we're collecting, how do we interpret the data, right? Who are we working with to interpret the data? And then how are we doing the reporting and utilization of that data to perhaps not only contribute to the evidence base around strategies that may be effective in intervening on structural racism, but it can also contribute to the evidence base about how can you then use these learnings to be able to say, well, we may not be able to do this ourselves, but we can partner with another group that can help us do this. So this is important in terms of really thinking through your whole, the beginning part of your evaluation plan and design, and then it impacts all the other steps in the evaluation process. So to do this well, in some strategy, we have talked through and provided some tools and tips and some thoughts around how you can actually do this as part of your planning design. How do you set it up to begin to have these conversations? What can you put in place to support being able to ask these questions in this way? And one of the first things that we feel very strongly about is that when it's ever feasible, we should be engaging those who are supposed to benefit from whatever that program or strategy should be. And they should be engaged in the evaluation process. But it's important that when we engage those individuals, we need to ask and understand and set realistic parameters for their participation so that this does not become a burden. It is, we're honoring what they think they can do, what they can give, and we are also engaging them in ways that make sense for them, while also understanding that for many, this could be a sacrifice. It can actually cost them in more ways than one. So when it's ever feasible, we want to be able to explore ways to help offset the cost of that participation, right? That could be honorariums for participating. It could be providing a meal, a transportation of vouchers, some combination of all of those. I think it's also equally important that we think about, as part of this engagement process, how are we creating user-friendly and tailored communication products for the individuals that we are engaging so they can understand, follow, be a part of, participate in the evaluation process as well. And not be put off by these long evaluation reports, but something that quickly gives them the information they need to be able to be constructive participants in the process. Another key consideration is that we really need to be cognizant of the power dynamics within our evaluation team. Evaluators tend to hold the power. We need to understand that and do what we can to share that power. And this could involve co-developing group agreements so that everybody understands how we're interacting, when we interact, how we share what we learn, how we make decisions, who gets to say in those decisions, and be very explicit and transparent about this upfront. And then have a process to monitor that, as well as a process for being able to address it if those things don't happen. Similarly, we need to be able to identify and address the capacity building needs, particularly of those, if we're engaging those who are supposed to benefit from this. We can't just start in like, okay, let's talk about a logic model. Some people may never have heard about a logic model. How do we do that upfront capacity building so that they understand the purpose of evaluation, understand the tools that we're using, and are able to actively participate as co-participants in the development process, in the planning and design process, as well as on the back end of interpreting the data and determining how we write up the reports and disseminate it. And I would say in some respects, maybe this bullet is even the most important, is like we need to do our homework, right? And I should say our homework, not your homework. Do our homework, right? Take the time up front in this process with your full evaluation team, build it in as a step to really review what's already been done on this subject that's going to help you better understand how structural racism may have impacted your problem at hand, right? You want that to be an intentional focus of a literature review, an environmental scan, potentially some interviews with experts in the field, the data that you're looking at, You want this to be the lens in which you are seeing the information so that you can have a grounded understanding of what impact structural racism may have and how that plays not only into your strategy, but the questions that you're going to ask as part of your evaluation, the data that you're going to collect, and the way that you interpret that data and those findings, particularly barriers and challenges that you might encounter along the way in the implementation process of your evaluation. Understanding the role of structural racism can give you some really great insight on why maybe you're not seeing the outcomes that you expected to see, because there's some other factors here at play than what you thought there were. And again, make sure you put the time aside and the resources to be able to do this so that you and your team, the full team, can engage in this type of learning and build this learning in throughout the process. Okay, so there's a reason why we call it evaluation, learning, and continuous improvement cycle. That learning is built in. And lastly, as evaluators, this is often a time where we need to put on our facilitator hat or engage an independent person as a facilitator, but we need to have a person, an evaluator, someone facilitating these conversations with this team so that we are asking those hard questions. We are exploring the role of structural racism, even if we don't necessarily use the term structural racism, although I would suggest not shying away from it, but for some conversations, maybe it's important to think of a different term. But we need to make sure that whatever term we're using, we are asking those hard questions. We are getting to the why. Why are these disparities here? What are the drivers? What are the historical and structural factors, discrimination that is leading to these disparities that we're seeing? And we would suggest that if you're doing this as a group, that you can use the systems tree that we presented earlier as a tool to help people understand this conversation, to guide them, particularly community members, so that you can work backwards and not just necessarily jump deep into, okay, let's get into mental models when we don't have that trust built. But you can start to build that trust in these conversations by starting with the symptoms and going to the patterns and trends. And it's important to really provide that space for disagreement and reflection here so that you can go through these hard questions, have a disagreement, come out on the other side, and that helps to build a trusting space. But maybe most importantly, it provides the opportunity to have shared understandings of the goals and expectations and limitations of what both the evaluation and the strategy can do with respect to structural racism. This is what I mean. Like, maybe not every strategy is going to be able to intervene on structural racism, but knowing the role that it plays, maybe there's an opportunity to be able to identify another way to use those learnings so that the learnings in combination with another set of learnings or as part of an evidence base can begin to provide guidance to others about some potential techniques or some other ways to help people think about how structural racism is affecting this particular problem. I'll turn this over to Anna to give us a summary.
As you can tell from everything Michelle described, there are very intentional steps. There's time that's needed to do this work with evaluation in service of equity. And we hope that you're convinced that investments need to be made in evaluations that address structural racism to get to health equity. And because by doing so, you'll be able to gain a deeper understanding of the power shifts that need to happen, which will be the foundation for what many people want to achieve, both new and stronger partnerships and collaborations across sectors, across people who have been advantaged and disadvantaged. And these partnerships and collaborations are what's needed for increasing advocacy to move the levers that lead to change. And that change, hopefully at the level of policies and practices that contribute to structural racism and health inequity. So remember, this approach in being explicit in addressing structural racism identifies where the changes are needed. So in the systems, in the policies, the partnerships at that systems level that Michelle talked about. So finally, I hope all of you take away that equity is in a constant state of change. And that's why we need this cycle of continuous improvement and learning. And we need to focus on the systems level, the drivers of health inequity, structural racism. And we need to conduct evaluations that ask the questions, those really hard questions, and probe to find out where improvements to strategies are needed to advance health equity. And then by doing so, we can be evaluators who use our evaluation methods of inquiry through those various questions that Michelle posed in the overlay of the regular logic model, to put the focus on systems change, starting with the way we plan and design our evaluation, so that our measures end up being focused on the outcomes that make a difference in health equity. With that, I want to now open it up and to discussion, reactions, your feedback, questions that you may have. Yeah, Shannon, definitely daunting comes to mind. Great to hear successes in doing the work.
So yes, I think it is daunting. And that's one reason why we try to think very intentionally about how you can do it in a way that, I mean, it's not easy, but it's one that will actually get you closer to being able to have those conversations. And I think where we've had successes is when we've been able to work with our client or funder or whoever we're working with. And they also appreciate the importance of involving the folks who are supposed to be benefiting, as well as other stakeholders and partners in this conversation. And have set aside that time upfront in the beginning to do not only ask these questions, but to do some relationship building, right? So people can know each other a little bit, feel a little more comfortable, and create the space where you can ask some of these questions where there's bound to be disagreement. But because people know each other, the disagreement it's somewhat easier to work through. Not always perfect, right? Mm-hmm. Which is one reason, as an evaluator, this is one of them times when you really got to think about your facilitation skills. And as my colleagues Amber Trout and Jasmine Williams Washington always say, like, being able to know how to navigate that resistance, to be able to have those conversations and intentionally using those skills to navigate that resistance. When we're able to do that, and everybody is willing to take the time up front, as well as recognizing, respecting what it takes for folks who are not evaluators to participate in this, even your partners when they're not evaluators, that becomes an incredible benefit, and it sets the stage for that collaborative partnership throughout the rest of the project to be able to get to the place where the findings you have are useful not only to you, the funder, but to the community as well. And I like Michael's suggestion too, when you're teaching communities how to do the research and outreach, right? So thank you. You remind me too, like taking the time to explain the different steps in the project, building that capacity, helping people be able to know what it means to do an interview, maybe training them to do interviews. They're doing some of the interviews themselves, but giving them, like not giving them, but helping them build that capacity to do themselves does create another level of investment in this. And I think it's another way that you can have more success in the long run.
Yeah, and what I hear you saying, Michelle, also just importantly is just being so open and honest about what evaluation can do. We're limited if the questions aren't really getting you to asking about those root drivers of health inequity. So being honest about the time it takes to have those conversations, to delve a little deeper, to put that time into identifying those drivers and then being able to make progress. So I think that leads to success as well.
And I think as evaluators, being open to also talk about what we don't know and what we know and our own bias, and having a vulnerability in those conversations as well, so that others can also have the vulnerability.
Any other questions or thoughts that, or experiences that people have had in doing this work? I see someone's talking about struggling as an evaluator, feeling more passionate about measuring health equity than the program, I think, implementation team. And evaluating health equity requires action, not words, on the program side as well. Fully agree with that. And asking for suggestions for how to evaluate health equity when the program side is committed in words, but maybe not so much in action. Yes, definitely. I think that, as Michelle described, that process of inquiry, it also feeds into understanding how the program, the strategy needs to adjust to be able to address those root causes of inequity. So and we understand that piece of resistance, and often program implementers want to get the doers, so they want to get into their doing mode, where we're saying to step back and have more time for asking the deeper questions before getting into the doing, so you understand what the doing is for. And then you're able to implement in a way that's actually getting you to health equity, rather than relying on the evaluator to measure something that the strategy isn't really getting to health equity.
Yeah. Yeah. And I think this is also one of those, not having the buy-in that you need from the program side is a definite challenge all the way around. I think this is where that relationship building and having those conversations is key too. And then thinking about, as you plan your evaluation, what can get you that buy-in. I'm not saying you all haven't done this, but are there some questions that are of particular interest to the program team? Is there some data of particular interest to the program team? Is there a way to involve the program team in this? And then sometimes it's about helping the program team better understand the relationship between the health outcomes they're trying to achieve with the bigger question of health equity. When they get the understanding of how their work, which they may see very focused on health outcomes, contributes to a larger conversation around health equity, that could be a light bulb moment that helps to build a buy-in. It's not guaranteed, but it could be a light bulb moment.
We also got a question on when we find that the goal changes when working on health equity, such as the goal goes from outreach and education to services, and then to policies, then to funding, and then addressing specific laws. And how do you know when to shift your priorities or evaluation to accommodate this? And Michelle, you talked a lot about moving in that direction.
Yes, but it's a challenge, right? It's a challenge if you haven't defined this upfront as a developmental evaluation and you haven't planned it as a developmental evaluation. And maybe that's one thing that we as evaluators need to do is some of these spaces is begin to have these conversations with our funders and with our program people about the appropriateness of taking a developmental evaluation perspective that allows you to do these shifts more often. Doesn't guarantee that they're easy, but it at least creates the mental space for people to think about it. And I do, one of the reasons why I think having these conversations as much as you can up front and then throughout the process is that I'm hoping it leads to, because it has for us, to share an understanding of what the expectations are for the evaluation as well as the limitations. And so sometimes maybe what can happen is that there's a conversation around how do we do this in phases, right? Because all these things are important. We do want to know how the outreach and education is working, but we also need to know how the policies is working and how the funding is working. And there could be places where you can do that in a more phased approach and using learnings from one to help inform the other, rather than like pushing everything aside because now you've got a new shift. It's just a way to accommodate the shift as another level of understanding as you're moving closer and closer to health equity. I hope that made sense. Then I see we have another question. As a program evaluator for health department, I'm limited in terms of co-creating anything evaluation related with community-based organizations, my program funds. What would you prioritize given constraints of bureaucracy and power dynamics? That's hard for me to say, not knowing what would be most useful to the group that you want to co-create with. And I would say maybe having that very transparent and frank conversation with the group that you would like to co-create with, and having that conversation about, what is it that you need and want and would be most beneficial? Because it could be as simple as, I just don't want a 5-page report. Give me a 1-page summary that's more visual, and that's great. So there's different ways to think about co-creation, but possibly having that conversation with those organizations to figure out what's of most use to them, but then being transparent about your limitations, given where you are, and then maybe coming together with ideas about products that meet both your needs or meet their needs more so, if that's the most important consideration at that moment. but is within your power to actually do. I don't know if you had any thoughts about that, Anna, but.
Yeah, and it's tricky when there is that power dynamic with the funding. And so I think
Bureaucracy.
yeah, I think, yeah, the buy-in, the trust that needs to develop in order to really conduct evaluations that are meaningful to the community, and ultimately, hopefully, to the health department as well, to build some consensus on what that is, and not jeopardize funding by being transparent and honest and open about the issues that exist and that need to be addressed.
And I'm sorry, my Americano is wearing off this afternoon, so I'm not sure what TOCs is an abbreviation for. Do you know, Anna?
I thought table of contents at first, but then I realized it might be theory of change.
Is it theory of change?
Yeah.
So if it's theory of change, I would say not all theories are, thank you. I would say not all theories of change are from a systems perspective. I think you need to be intentional about thinking through a theory of change from a systems perspective. And sometimes maybe for your particular program, it does make sense to think about it first from how you envision what the program is going to do, and then come back and have that conversation of, well, if we apply a systems lens to it, how does it shape this conversation differently? So that you can see, so with the systems lens, one of those things we can and cannot intervene in on, what is in our purview, and even for those things that we can't personally or programmatically intervene in on, is there a way for us to think about some creative ways to contribute to that conversation, whether that's a partnership with someone else who is intervening on it, or some other ways of being able to help inform advocacy efforts, or whatever that looks like. That could be another way of doing it. But no, now, whether or not we want to say that we think all theories of change should have a systems perspective is a different question. But for an evaluation, not all of them do.
We also have a question on if we can develop a systems lens if we don't have disaggregated data. Mm-hmm. Can we move forward with any progress, especially if the organization does not have plans for disaggregated data anytime soon? I think that's a good question, because there are many communities that either don't have don't collect data in that way by race or other groupings, or feel like there's a very large majority and group, and if they disaggregated the data, that there might be some very small groupings and wouldn't want to make that data public to be less anonymous. But I would say that we talked about the disaggregated data being part of the disparities, the symptoms that you can see that indicate that you might have a problem. But you can also, if you go back to the slide that Michelle explained about using a systems lens to explore structural racism, there were many questions there that you might be able to ask without that disaggregated data about the systems, about the mental models, the narratives that are going on, to still ask really good questions to understand what the root causes are there in your inequities. Disaggregated data is great. Hopefully you'd be able to get there at some point, but you can still start by asking other questions.
Yeah, and I also just want to, and I don't think I probably said this clearly enough. In this particular context, when I'm thinking about disaggregated data, I'm thinking about quantitative data, but also qualitative data. Like, if you don't have the quantity of the quantitative data that you need to be able to say this is disaggregated data, but you may know from either prior knowledge or from experts or whoever's in the field that this is a particular part, this problem shows up differently for this group, and there's a lot of other factors that have come to play, then that's sometimes where the qualitative data can be really meaningful and impactful, to begin to highlight some of these differences, to begin to build a case for it, and to begin to build a case for potentially doing more quantitative data down the road. But it allows you to move forward with that data to begin to talk about and explain what are you seeing in some of these disparities and these symptoms, and how it's differentially impacting certain groups in a particular community. The next question is, I would love to hear some examples about how you've managed a relationship with donors and sponsors of evaluations. They often like the idea of an equity focus, but aren't willing to fund meaningful equity work and the deep partnership it requires. Yes. Yes, that is definitely a case. And it's challenging. There's a number of things. There's a number of places where for us, we begin to tackle that. And sometimes for us, it's in the proposal stage, right? It's in the RFP stage. If we read an RFP and wonder if that's the case, then we have very explicit questions that we put to the funder in that process of when we have those initial conversations and sort of interview with a potential funder. It's also in what we propose and how we talk about what we propose and why it's important to fund something. There have been times when we've decided not to do the work because we didn't think enough was being sufficiently invested in those conversations. I think if you are already doing the work, then sometimes what could happen is that if it's feasible, you can think about ways to do whatever it is you want to do around this equity question, maybe on a smaller scale at first, just to demonstrate the value of what it could provide and how important it could be, and then begin to set the case for maybe potentially getting that buy-in for them to do something larger and bigger. But I fully recognize what a challenge this is. And it's part of the reasons why we're actually doing this type of webinar, is so that we can begin to have the conversation that says, this is important to evaluation in the service of equity, and you need to invest the time upfront to do it. And so that the more those conversations are happening and the more people see that, then hopefully the more willingness is to actually fund it the way that it needs to be funded.
Another question that came up, and I think people have asked this in different ways in the registration questions as well, is what metrics do you recommend for looking at progress and on more systemic drivers of inequity? We gave this some thought before coming into this webinar as well, and really wanted to suggest that after you go through this process that we're suggesting, this framework, that will give you those metrics. We don't have a list of metrics that you might use, but it's really about understanding your context, the systems at play within the work that you're doing and the communities that you're looking at, the topics that you're addressing, to really dig in to understand what might be driving those inequities. And then that will lead you to being able to ask those questions that end up being your evaluation questions that then you can measure, are you making progress on? So the metrics really stem from doing this work through the frameworks that we're describing today.
Yeah. I mean, there's been some work done where people create sort of like a racial equity index on particular factors, like maybe trying to see what's the racial disparities in the community between those who African Americans who are 25 and older and have completed a college degree, and then difference between African Americans and whites on that, and then being able to use as sort of like an indicator of a disparity and to what extent does it occur, and then use that to then pull together lots of different sort of indicators of racial disparities, and then see how and what impact that might be having on a particular outcome. That's a more quantitative approach, a way of doing it. And it can work as long as everybody buys into the way that you have defined those indicators of disparity. And if there's a common agreement among folks for that, then that is one way to approach this, and one way that you can continue to do this over time and across different communities. So a lot of it depends on, as Anna was saying, what is the health topic you're looking at? What's the role of structural racism in that? Is it something that lends itself to that more quantitative measurement? Do you have enough data to be able to develop these sort of disparity indicators that can be monitored over time? So there's a number of different factors that go into what is the right measurement for your particular evaluation. and I'll take this. So whenever I was referring to the difference between healthy outcomes and health equity, for me, healthy outcomes was more like what's happening at the individual level or groups of individuals and there's a particular outcome of interest. But to see whether or not health equity as a population level has actually changed, that's more than just maybe this group has experienced some improved health outcomes as a result of the intervention. But that may not necessarily mean that there's been improved health equity, right? It kind of gets to that question of you can have two groups who are continuously experiencing improved health outcomes, but the disparity disparity remains. So the health equity gaps remain, right? So that was a way that I was using the terms outcomes versus equity in that context. I think we might have time for one more question. Is this the last one? At times, evaluation plan and outcomes are presented as the fund is part of a proposal. The evaluation is hired after funding is received. How can we troubleshoot? We talk about these. How do we change the conversation? Yes, that's what we were talking about earlier. I'm actually going to put a plug in. I'm actually going to put a plug in because it is on our community science website as well, for the webinar that was conducted by Aaron Petrout and Jasmine Williams Washington on navigating resistance, because they really talk about some very discrete tools that you can use to move a conversation forward, to address these the barriers and the stumbling blocks and some of these sources of resistance, so that you can have these larger conversations and get people to the point where everybody's ready to come to the table and do this in a more collaborative way. So I would say, one, take a look at that. But then two, if you talk about it from the point of hire, just also want to say this, you have usually that kickoff meeting. You have that place where you all talking about what this work is going to look like, being as transparent and upfront during that kickoff meeting about why you think it's important to have these conversations, how will it impact the evaluation, and being tangible about that in a way that it can change not only your approach, but your outcomes and your questions and the utility of the evaluation and the dissemination and uses of it, I think is how you begin to shift it. It may not all happen at the end of the kickoff meeting. It may take a couple conversations, but that's how you can begin to shift that conversation. I didn't know if you had anything else you wanted to add, Anna?
I do not. Just thank you, everyone, for attending. Thanks for your questions. Thanks for being thought partners with us. We appreciate it. And thank you, everyone. Have a good rest of your day.
Thank you.